Welcome to the Hospital Medicine Unplugged podcast.
Thank you for having me.
Imagine a clinical scenario where the loss of a mere 5% of a patient's lung volume suddenly and irreversibly triples their risk of mortality.
Right, it's a terrifying metric when you really think about it.
It really is. Today we are looking at mixed connective tissue disease. It's a condition so incredibly rare that, many practitioners reflexively mislabel it.
Absolutely, they lump it in with other syndromes.
Exactly. Yet it is so relentlessly aggressive that a delayed diagnosis can literally cost a patient their life.
Which is why we need to unpack it today.
So as a hospitalist or an attending physician admitting complex autoimmune cases, you are routinely confronted with diagnostic ambiguity.
You see it all the time on the floor.
Right. A young patient arrives with severe joint pain, striking fatigue, and swollen fingers.
It's a classic undifferentiated presentation.
And your instinct might be to broadly categorize them under systemic lupus erythematosus or maybe early systemic sclerosis.
Because you assume the precise nomenclature won't immediately alter your acute management strategy.
Exactly. You assume it doesn't matter right this second. But this deep dive is designed to deconstruct that exact assumption.
I mean, we really have to critically evaluate the modern clinical profile and those stringent diagnostic criteria.
We do. We're going to look at the precise pathophysiological mechanisms of mixed connective tissue disease.
And we'll navigate through those deceptive early sentinel signs before confronting the devastating pulmonary complications.
Right. Those complications are exactly what defines the mortality curve here.
And we'll analyze the specific evidence-based management algorithms that, frankly, fundamentally diverge from those used in overlapping conditions.
It is a critical distinction to make, and I think largely because our historical understanding of this condition has undergone a rigorous evolution over the past decade.
Well, the logical starting point for understanding how to approach this disease clinically is to ground ourselves in its epidemiological reality.
Right. We have to start with the numbers.
We do. And the first concept you must integrate into your clinical reasoning is the absolute rarity of the disease.
It's mathematically the least common of the established connective tissue diseases, right?
Exactly. When we analyze robust population-based incidence metrics, the data reveals a remarkably low occurrence.
We're talking about 1.9 to 2.1 new cases per 100,000 individuals annually.
Right. And the point prevalence sits at just 3.8 per 100,000.
Which is incredibly low. To contextualize that for you as a practicing clinician, you could work as a busy hospitalist in a mid-sized tertiary care center for 10 or 15 years.
And theoretically, you might only encounter a true, definitively classified presentation of this specific phenotype once or twice in that entire span.
I mean, that really puts it in perspective. And furthermore, the demographic distribution reveals a profound female predominance.
It does. The aggregate data indicates that female patients account for roughly 84 to 88% of the total affected population.
However, when you dissect the epidemiological literature further, you uncover a notably wide variance in the reported female-to-male ratio.
Right. You see cohorts ranging from 3 to 1 all the way up to 9 to 1.
That statistical variance in the sex ratio immediately stands out to me.
It's a huge spread.
It is. A range spanning from 3 to 1 to 9 to 1 suggests that our diagnostic capture of the disease is, well, highly sensitive to external variables.
Absolutely. I suspect this variance is heavily influenced by the specific population cohort being studied.
Or perhaps the evolutionary era of the diagnostic criteria applied. I mean, in the 1980s versus the 2020s, our serological assays have completely transformed.
They've become infinitely more precise.
Right. But I want to bring this back to the clinical reality of the physician on the floor.
Sure.
Because the point prevalence is so exceedingly rare at 3.8 in 100,000, many physicians might mentally group these patients into a broad generic bucket.
They just call it a lupus scleroderma overlap and move on.
Exactly. Functioning under the assumption that pinpointing the exact alphanumeric label does not significantly alter their immediate clinical posture.
Which is a dangerous way to practice.
So at a population level, when you are standing at the bedside, does definitively labeling this rare entity actually change your initial management trajectory?
I mean, compared to how you approach those much more common systemic autoimmune diseases.
Yeah.
Yes, definitively.
Okay, so you'd argue against that overlap assumption.
I would strongly argue against that assumption. Definitively labeling the disease dramatically changes both your immediate prognostic modeling and your longitudinal monitoring algorithm.
Right.
When you evaluate a patient with an undifferentiated autoimmune presentation, your pretest probability for mixed connective tissue disease is mathematically the lowest.
It's the lowest among all your differential diagnoses.
Exactly. Therefore, relying on a vague overlap categorization is an inherently dangerous clinical posture.
Because the specific morbidity profile we see here diverges significantly from classic systemic lupus erythematosus or systemic sclerosis.
Right, particularly the trajectory of the pulmonary vasculature.
So to secure this diagnosis and justify moving a patient out of that general overlap bucket, we rely on a strict serological requirement.
A very strict, non-negotiable requirement. The presence of high-titer anti-U1 RNP antibodies is the absolute hallmark here.
It's the sine qua non for this diagnosis.
Yes. If that high-titer antibody is absent, the diagnosis is excluded, regardless of the clinical presentation.
Well, I want to push back on that serological absolute for a second.
Okay, go ahead.
Because while we rely on the Sharp and Kasakawa criteria, which demonstrate excellent sensitivities of 97.3% and 93.3% respectively, we have to acknowledge the overlap.
There is always overlap in autoimmune serology.
Right. The presence of anti-U1 RNP is not exclusively isolated to this single disease.
No, it's not.
We know it appears in roughly 25 to 30% of patients with established systemic lupus erythematosus.
That's a well-documented statistic.
So if I ordered an anti-nuclear antibody test that reflexes to an extractable nuclear antigen panel, and the U1-RNP comes back strongly positive, the cognitive bias is to instantly anchor on the mixed phenotype.
I see where you're going with this.
Right. I mean, if a lupus patient has that exact same serological marker 30% of the time, how specific is this test, really?
It's a fair question.
It seems like we are ultimately forced to rely on gross physical examination features to make the final differentiation.
Specifically, the presence of scleroderma-like tissue changes.
Exactly. Swollen hands, sclerodactyly, and severe gastroesophageal reflux.
Right.
So if we require those physical features to confirm the disease, doesn't that imply the serology itself is fundamentally insufficient to define the pathology?
You are identifying a crucial diagnostic tension there. But I would reframe how we view the serology.
How so?
Well, it is not that the serology is insufficient. Rather, it is only the first half of the biological equation.
Okay, that makes sense.
You are entirely correct that up to 30% of systemic lupus patients possess anti-U1 RNP. However, in those lupus patients, it typically presents at lower titers.
Or its clinical impact is just overshadowed by more dominant autoantibodies.
Exactly, like anti-double-stranded DNA or anti-Smith. To truly understand why the high-titer presence of anti-U1 RNP is so tightly bound to this unique clinical phenotype, we have to look deeper.
We need to examine the pathophysiology at a molecular level.
Precisely. The U1 ribonucleoprotein is a critical component of the spliceosome.
And for those visualizing this, think of the spliceosome as the cell's master film editor.
That's a great analogy. It's continuously splicing and editing pre-messenger RNA into readable genetic instructions.
So when the immune system breaks tolerance and targets the U1 RNP, it is not merely tagging a cell for destruction.
Right. The autoantibodies actively bind to this editing machinery, forming dense immune complexes.
And these specific complexes have a profound affinity for the vascular endothelium.
Yes. When they deposit, they trigger a distinct cascade of endothelial apoptosis and upregulate specific adhesion molecules.
Which unleashes a dual pathway response.
Exactly. It promotes acute inflammatory debris, which mimics lupus, but simultaneously triggers an aggressive fibrotic cascade.
And that fibrotic cascade is what mimics systemic sclerosis.
Right, you get both at the same time.
That structural analogy of the film editor is incredibly helpful. It clarifies why the damage isn't just generalized inflammation.
It's a highly specific disruption.
A disruption that leads to both inflammatory and fibrotic architectural changes. And that brings us directly to the roughly 3 to 7% of patients who fail to meet the Sharp or Kasakawa criteria.
Even though they have some clinical signs.
Right. I assume these are patients presenting very early in their disease course.
Usually, yes.
Yeah.
Before the full microvascular injury has manifested into observable tissue pathology.
So when we look for the earliest bedside evidence of that endothelial injury, we consistently arrive at Raynaud phenomenon.
It is recognized as the definitive sentinel clinical sign.
Documented in 80 to 91% of these patients. But, Raynaud phenomenon is incredibly common in the general, otherwise healthy population.
It is very common, especially in young women.
Right. Primary Raynaud's is often considered a benign, exaggerated, sympathetic response to cold.
Just a functional vasospasm.
So, in primary care or general internal medicine, at what point does a standard presentation of cold-induced digital ischemia warrant the escalation to a full anti-U1 RNP diagnostic workup?
Well, that is a threshold every clinician must clearly define for themselves.
Because you want to avoid massive overtesting.
Exactly, while simultaneously preventing a missed early diagnosis. In primary Raynaud phenomenon, you are dealing with a purely functional, reversible vasospasm.
The architecture of the blood vessel is entirely intact.
Right, it is simply constricting inappropriately. You can think of it as a temporary kink in a garden hose.
But the pathophysiology of secondary Raynaud's in the context of this connective tissue disease is entirely different.
Entirely different. You are no longer dealing with a functional spasm.
You are dealing with persistent endothelial apoptosis.
Yes, profound intimal proliferation and eventual structural obliteration of the digital microvasculature.
It is more akin to pouring concrete into the plumbing rather than just kinking the hose.
That's exactly it. So you should immediately escalate to a comprehensive autoimmune serological workup when the Raynaud phenomenon is accompanied by structural signs of tissue ischemia.
Like what specifically?
This includes any digital pitting, ulceration, or abnormal capillary loops visualized on nail fold capillaroscopy.
Right, those are clear red flags.
Furthermore, you must aggressively investigate if the Raynaud's presents alongside subtle systemic symptoms.
Things like unexplained fatigue, arthralgias, or that classic puffy hand sign where the fingers become uniformly swollen.
Exactly. The timeline of that progression is equally important for you to monitor.
Because isolated Raynaud phenomenon can precede the onset of systemic clinical features and positive serology by months.
Or in many cases, several years.
Therefore, if you are treating a patient who presents with new onset severe refractory Raynaud phenomenon, particularly in their late 20s or 30s, that patient requires vigilant longitudinal monitoring.
They are in a very high-risk window for evolving into definitive systemic disease.
And while Raynaud phenomenon is the visible external manifestation of this vascular pathology, we have to recognize that the exact same obliterative fibrotic changes are quietly occurring internally.
Which directly introduces the most lethal aspect of the disease.
The pulmonary system. Pulmonary complications dictate the ultimate trajectory of this condition.
They serve as the primary drivers of patient morbidity and mortality.
Let us dissect the data surrounding interstitial lung disease because it's staggering.
It really is. In longitudinal tracking, approximately 27.9% of patients develop clinically significant interstitial lung disease.
But the overall prevalence of radiographic lung involvement is alarmingly higher, spanning from 41 to 52%.
Half the patients essentially have some degree of radiographic involvement.
When reviewing the literature, the specific predictors for interstitial lung disease progression stood out to me.
What stood out specifically?
Well, elevated anti-RNP titers, the presence of anti-Rho52 antibodies, male gender, and paradoxically the absence of arthritis.
Ah, yes. That paradox is arguably one of the most fascinating aspects of autoimmune pathophysiology.
It is highly counterintuitive to a clinician that the absence of severe joint inflammation would predict a more fatal pulmonary outcome.
It seems backwards, right?
Yeah.
However, this observation perfectly illustrates the concept of divergent phenotypic tracks.
Can you break that down for us?
Of course. When a patient's immune system severely dysregulates, it tends to channel its pathological energy predominantly down one of two pathways.
Okay, so it chooses a lane.
Essentially, yes. One pathway is highly inflammatory, driven by cytokines that promote prominent synovitis, erosive arthritis, and pleuropericarditis.
It is loud, painful, and immediately apparent on a physical exam.
Right. The alternative pathway is predominantly fibrotic.
Driven by profibrotic mediators like transforming growth factor beta.
Yes. This fibrotic track relentlessly targets the lung parenchyma, leading to progressive tissue sclerosis and interstitial lung disease.
So if a patient is locked into that fibrotic pathway, they may completely lack the acute, painful, inflammatory joint symptoms.
Exactly. Their clinical presentation appears deceptively quiet to the examining physician.
While irreversible architectural distortion silently accumulates in their lungs.
And the mortality data attached to that silent fibrotic accumulation is unforgiving.
It really is. The literature rigorously defines severe lung fibrosis in these patients as the involvement of greater than or equal to 5% of the total lung volume on high-resolution imaging.
Just 5%.
Right. Hitting that 5% threshold increases the patient's mortality risk by an astounding 2.9-fold.
it nearly triples the mortality.
As a clinician accustomed to seeing massive bilateral infiltrates or severe structural destruction before patients face imminent mortality, that specific threshold feels incredibly small.
It does seem small compared to what we usually look for in ARDS or severe pneumonia.
Why does such a seemingly minuscule loss of total lung volume translate into a massive mortality multiplier?
Well, it suggests that even a minor fibrotic burden permanently alters the fundamental mechanics of the lung.
It does permanently alter the mechanics, but the critical insight is that the 5% threshold is not merely a measurement of lost alveolar surface area.
Right. A patient can easily survive with a 5% reduction in gas exchange capacity.
Instead, that 5% threshold serves as an incredibly sensitive surrogate marker.
A marker for an active, aggressive, and autonomous fibrosing phenotype.
Once the fibrosis reaches that level, it indicates that the disease process has achieved sufficient momentum to continuously progress.
It acts like pulling a single structural thread that, well, it begins to warp the entire fabric of the lung's compliance.
Furthermore, that interstitial destruction inevitably induces secondary hemodynamic consequences,
Chief among those consequences is pulmonary arterial hypertension.
which develops in approximately 7.6% of these patients.
While the prevalence is relatively low, its impact on survival is catastrophic.
It is the leading cause of mortality in this patient population.
In a highly detailed longitudinal cohort study out of Hungary, pulmonary arterial hypertension accounted for 31% of all mortalities.
The pathogenesis of pulmonary arterial hypertension in this specific disease state is uniquely aggressive.
And it directly relates to the dual pathway response you described earlier regarding the immune complexes.
Right. These patients suffer from a devastating dual hit to their pulmonary vasculature.
They endure the structural obliterative vasculopathy that we traditionally associate with systemic sclerosis.
But they are simultaneously subjected to an active inflammatory pulmonary arteritis that is characteristic of systemic lupus erythematosus.
It's the worst of both worlds, hemodynamically speaking.
Before we transition to how we manage that dual hit, there is a striking demographic paradox hidden within the interstitial lung disease data that we must unpack.
The gender distribution data.
Yes, we established at the very beginning of our discussion that the epidemiological reality of this disease is overwhelmingly female.
Accounting for up to 88% of all cases.
Yet the data clearly identifies male gender as a primary independent predictor for the progression of interstitial lung disease.
It's a fascinating dichotomy.
Are we observing a biological scenario where the disease is significantly harder for men to initiate, but exponentially more fibrotic and aggressive when their immune tolerance finally breaks?
Yes. The clinical data strongly supports exactly that biological scenario.
The underlying mechanisms must be highly complex.
They are, likely involving the profound role the X chromosome plays in immune regulation and autoantibody formation.
Right, the genetic and hormonal milieu in men appears to provide a higher threshold of protection against the initial break in immune tolerance.
However, once that high threshold is breached and the disease initiates, things change rapidly.
The resulting phenotype in male patients is frequently far more severe.
Very severe, treatment refractory, and heavily skewed toward the fibrosing track rather than the inflammatory track.
This gender-based paradox provides you with an immediate, highly actionable risk stratification tool.
It does. If you are admitting a male patient with a confirmed diagnosis of mixed connective tissue disease, your clinical index of suspicion for rapid, silent pulmonary decline must immediately elevate.
You must pursue baseline pulmonary function testing and imaging with far greater urgency than you might for a patient presenting purely with inflammatory arthritis.
Absolutely. Time is tissue in these scenarios.
But we must balance the grim reality of silent pulmonary fibrosis and fatal pulmonary arterial hypertension with the broader long-term prognostic data.
Which is actually surprisingly optimistic, all things considered.
It is. When you review the modern survival rates, they present a stark contrast to the legacy literature from previous decades.
We are currently observing a 5-year survival rate of 98%.
A 10-year survival rate of 96%.
And a 15-year survival rate of 88%.
In fact, robust population-based studies demonstrate that the overall mortality of this cohort is not significantly different from the general population.
Which is an incredible achievement of modern medicine.
Furthermore, approximately 45% of patients achieve a sustained state of clinical disease remission during their follow-up period.
But the most debated statistic in the literature is this next one.
Right. 25.8% of patients progress to a differentiated connective tissue disease over a median time of 5 years.
Specifically, 15.8% evolve into classic systemic sclerosis.
And 10.6% evolve into classic systemic lupus erythematosus.
So, to reconcile the high lethality of the pulmonary complications with that exceptional 98% 5-year survival rate, you have to credit the profound impact of modern protocols.
Proactive early detection protocols have completely changed the game.
In contemporary clinical practice, we're identifying the disease much earlier in its course.
And intervening with targeted immunosuppression long before the dual-hit vasculopathy renders the pulmonary hemodynamics irreversible.
The disease naturally exhibits a highly bimodal distribution,
Nearly half of the patients respond beautifully to therapy and achieve remission.
while a distinct, high-risk subcohort faces relentless fibrotic or vascular progression.
But the phenomenon you highlighted, disease evolution, is arguably the most biologically fascinating aspect of this entire condition.
I completely agree. What does it mean mechanistically that over a quarter of these patients eventually shed their mixed clinical phenotype?
And fully differentiate into a classic disease state.
At a molecular level, this likely represents the concept of epitope spreading.
The immune system initially focuses its dysregulated attack exclusively on the U1 RNP autoantigen.
Producing the mixed clinical picture we see early on.
But over a median period of 5 years, the immune response broadens its targets.
It may generate antibodies against double-stranded DNA, fully pushing the patient's phenotype into classic systemic lupus erythematosus.
Or it may develop anti-topoisomerase antibodies, fundamentally pushing them into systemic sclerosis.
That concept of epitope spreading completely reframes how we view the diagnosis.
It really does. If over a quarter of these patients eventually evolve into classic systemic lupus or systemic sclerosis after a median of 5 years, we have to ask a difficult pathophysiological question.
Is it possible that mixed connective tissue disease is not a distinct, standalone pathological destination at all?
Could it simply be a transient early-stage evolutionary phase?
A biological clinical waiting room, so to speak, where the dysregulated immune system is simply gathering momentum.
And finalizing its ultimate clinical trajectory.
That specific debate remains central to modern rheumatologic taxonomy.
There is a strong contingent of purists who argue exactly that this is merely an early overlap syndrome destined to eventually declare itself.
However, the prevailing counterargument is deeply rooted in the clinical data you just cited.
Right. While roughly 26% of patients evolve, that leaves approximately 74% who do not.
The vast majority of these patients maintain their specific anti-U1 RNP-mediated mixed phenotype indefinitely.
They never develop the classic antibodies required to differentiate.
Regardless of whether you view the disease as a permanent pathological destination or a transient biological way station, the clinical reality remains identical.
The immediate threat of pulmonary complications demands aggressive, targeted, and highly specific treatment protocols.
You cannot withhold therapy waiting for the disease to differentiate, while a patient's functional lung volume is being permanently destroyed.
That urgency directly transitions our focus to the evidence-based management algorithms,
which mandates strict diverging treatment protocols depending on the specific organ involvement.
For the management of pulmonary arterial hypertension, the 2022 ESSERS guidelines provide definitive direction.
The pulmonary hypertension associated with this condition is treated via the exact same algorithmic approach as idiopathic pulmonary arterial hypertension.
This strategy aggressively utilizes endothelin receptor antagonists,
PDE5 inhibitors,
and prostacyclin pathway agents to lower pulmonary pressures.
However, there is a critical pharmacological distinction when comparing this disease to systemic sclerosis.
In systemic sclerosis-associated pulmonary hypertension, adding heavy systemic immunosuppression yields no clinical benefit.
Yet, in mixed connective tissue disease, adding heavy immunosuppressive therapy yields a profound benefit.
Specifically, high-dose glucocorticosteroids and cyclophosphamide.
You have a documented clinical benefit in lowering pulmonary vascular resistance.
It is essential that we deeply analyze why that pharmacological discrepancy exists.
Because it perfectly illustrates the underlying pathology we discussed earlier.
The standard vasodilatory agents work mechanistically to alter vascular tone.
Right. Endothelin receptor antagonists, such as bosentan or macitentan, work by directly blocking endothelin-1,
which is a potent endogenous vasoconstrictor and smooth muscle mitogen.
By blocking it, you halt pathological vascular remodeling.
PDE5 inhibitors, like sildenafil, prevent the degradation of cyclic GMP,
which directly enhances nitric oxide-mediated vasodilation.
and prostacyclins activate adenylate cyclase to increase cyclic AMP.
providing profound vasodilation while also exerting antiplatelet effects.
Those agents are universally applied in pulmonary hypertension.
But the reason cyclophosphamide works specifically in this patient population is due to that dual-hit pathogenesis.
Right. Cyclophosphamide is a potent alkylating agent that cross-links DNA and aggressively suppresses both T and B cell proliferation.
And the pulmonary hypertension here features an active, highly inflammatory vasculitic component driven by those immune complexes.
So cyclophosphamide halts that active arteritis.
In stark contrast, systemic sclerosis-associated pulmonary hypertension is characterized by a bland, non-inflammatory intimal proliferation.
Pure structural fibrosis without the active inflammation.
Exactly. Hitting a systemic sclerosis patient with high-dose cyclophosphamide provides absolutely no hemodynamic benefit to a scarred, non-inflamed vessel.
It simply exposes a vulnerable patient to severe infectious toxicity and bone marrow suppression.
Moving from the hemodynamics of the pulmonary vasculature to the architectural integrity of the lung parenchyma, we look at the management of interstitial lung disease,
which heavily prioritizes immunosuppression as the absolute first-line intervention.
Mycophenolate mofetil is the established, evidence-based standard of care for these patients.
Additionally, biologic agents like rituximab, which specifically depletes CD20-positive B cells, along with cyclophosphamide, have demonstrated objective improvements.
Quantifiable improvements in forced vital capacity in patients with connective tissue disease-associated interstitial lung disease.
Beyond pure immunosuppression, the antifibrotic agents nintedanib and pirfenidone have shown established efficacy,
specifically for generalized progressive pulmonary fibrosis.
Although we must acknowledge that the data specifically validating their use within isolated, purely mixed connective tissue disease populations remains frustratingly limited.
When evaluating the stabilization of forced vital capacity achieved by mycophenolate mofetil, it is crucial to understand the mechanism for longitudinal management.
Mycophenolate operates by reversibly inhibiting the enzyme inosine monophosphate dehydrogenase.
This action selectively starves T and B lymphocytes of the specific guanosine nucleotides they require for rapid proliferation.
By deploying this agent early, specifically during the inflammatory ground glass phase of interstitial lung disease, visualizable on high-resolution imaging, you can effectively halt the immune assault.
You stabilize the forced vital capacity and prevent the progression to irreversible architectural distortion.
However, the clinical dilemma arises when the forced vital capacity continues to persistently decline despite maximal optimized immunosuppression.
That decline indicates a fundamental shift in the disease biology.
From an active inflammatory process to an autonomous, self-perpetuating fibrosing process.
That is the precise moment we must consider the antifibrotics.
Nintedanib acts as a broad intracellular tyrosine kinase inhibitor,
effectively targeting multiple growth factor receptors, including platelet-derived growth factor and fibroblast growth factor.
Pirfenidone functions by downregulating the production of highly profibrotic cytokines, primarily transforming growth factor beta.
You highlight the mechanistic rationale perfectly.
But as a clinician practicing evidence-based medicine, I find the utilization of nintedanib and pirfenidone challenging in this specific context.
Because of the lack of targeted trials.
Exactly. We are deploying them based heavily on their proven success in generalized progressive pulmonary fibrosis trials, such as the INBUILD trial.
Right, but robust, disease-specific, randomized controlled trials dedicated exclusively to this specific patient cohort are virtually absent.
So how comfortable should a hospitalist or rheumatologist be deploying these extraordinarily high-cost medications?
Medications that carry severe dose-limiting gastrointestinal and hepatic toxicity profiles, mind you.
Right. How comfortable should we be using them without the validation of large-scale, strictly specific data?
It undeniably requires a calculated, intellectually honest acceptance of clinical risk.
It's a tough call at the bedside.
However, in clinical practice, when you are standing at the bedside of a patient whose lung function is autonomously deteriorating toward terminal respiratory failure, the physiological mechanism of progressive fibrosis must supersede the demand for a hyperspecific diagnostic label on a trial manuscript.
The antifibrotic agents target the downstream terminal fibrotic cascades that are biologically shared across all progressive interstitial lung diseases.
Entirely, regardless of the initial autoimmune trigger that started the cascade.
Therefore, deploying nintedanib or pirfenidone is mechanistically sound.
And arguably clinically necessary when the mortality risk of therapeutic inaction approaches 100%.
Because these immunomodulators and antifibrotics are heavy hitters with substantial toxicity profiles, and because the underlying pulmonary complications are relentlessly life-threatening, reactive treatment is fundamentally inadequate.
You cannot wait for a patient to report dyspnea.
We must institute a proactive, hypervigilant, and non-negotiable monitoring algorithm.
Since interstitial lung disease affects up to 52% of this population and frequently progresses silently without overt exertional dyspnea, regular multimodal clinical assessment is essential.
And given that pulmonary arterial hypertension remains the primary driver of mortality, we can't afford to miss it.
The required routine screening regimen mandates comprehensive pulmonary function tests,
High-resolution CT of the chest, and a baseline echocardiogram followed by serial echocardiographic monitoring.
The clinical nuance lies entirely in how you interpret these screening modalities.
On the high-resolution CT, you are evaluating the lung parenchyma for specific morphological patterns, most commonly non-specific interstitial pneumonia.
You must meticulously differentiate between ground glass opacities, which represent active reversible alveolitis,
And dictate the immediate initiation or rapid escalation of mycophenolate mofetil.
versus the presence of honeycombing and traction bronchiectasis.
Honeycombing indicates irreversible end-stage structural fibrosis.
It signals that the therapeutic window for pure immunosuppression has officially closed.
And the immediate addition of an antifibrotic agent is physiologically required to preserve the remaining viable lung tissue.
Regarding echocardiography, you are utilizing it strictly as a non-invasive gatekeeper for pulmonary arterial hypertension.
You cannot simply look for a gross estimation of right ventricular systolic pressure on the report.
You must scrutinize the raw data, the tricuspid regurgitant jet velocity, the precise right ventricular size, the presence of septal flattening during systole, and right atrial enlargement.
These subtle right-sided morphological changes dictate exactly when you must commit the patient to a definitive right heart catheterization.
To invasively measure pulmonary hemodynamics and initiate endothelin receptor antagonists.
We acknowledge that interstitial lung disease progresses chronically over years, but performing serial high-resolution CT scans exposes a relatively young, predominantly female patient population to a highly significant burden of cumulative ionizing radiation.
It is a profound clinical tension that requires disciplined stewardship of our diagnostic tools.
As clinicians, how do we responsibly balance the absolute clinical necessity of catching that critical 5% lung volume fibrosis threshold against the long-term oncologic risk inherent in our own rigorous, protocol-driven surveillance?
You mitigate that radiation risk by utilizing pulmonary function tests, specifically the diffusing capacity for carbon monoxide, as your primary high-frequency surveillance tool.
You reserve the high-resolution CT strictly for when there is a meaningful, reproducible decline in the forced vital capacity or the diffusing capacity.
Or when there is a clear documented change in the patient's exertional tolerance.
We do not image simply for the sake of imaging on a calendar schedule.
We image when the physiological parameters strongly suggest the microarchitecture is actively deteriorating, thereby justifying the radiation exposure to guide an immediate therapeutic escalation.
As we conclude our extensive analysis of this complex clinical profile, we must return to the concept of disease evolution we evaluated earlier.
It really forces us to consider the future landscape of rheumatology as a specialty.
As our serological testing arrays become increasingly hyper-specific, and as advanced genomic and transcriptomic profiling capabilities integrate into standard clinical practice, will the broad phenotypic umbrella term mixed connective tissue disease eventually become entirely obsolete?
It's very possible. We may soon reach an era where we no longer classify these complex patients by a mixed outward clinical presentation,
but rather by their precise, individualized molecular driver mutations, fundamentally redefining how we construct and interpret our autoimmune taxonomy.
It would be a fascinating evolution to watch.
Thank you for joining us. If this was helpful, give us a follow, and we'll see you next time on the Hospital Medicine Unplugged podcast.